Hello?
Hello? Yeah.
What I said is we install this WebEx application on the Android.
Yeah.
Have voice at least, but unfortunately it does not run well on GNU Linux. Lux is not free software. So, we can talk now, and I guess on the nation we can share the screen, but you are welcome to ask any questions you may have. You can use Google Hangouts. I'll be happy. I sent the doctor an invitation now on Google
Okay.
Hangouts, so I'm flexible.
So, Lois, you can start talking now.
Good morning, everybody. Good morning, Dr. Cello. I don't know where you were, and Dr. Bart. For me to be here today and talk about GNU, which is a health information system that's been running in different countries and of institutions, from small private doctors to large hospitals. The GNU Health project started on 8, and the idea behind it was public and within public health care, primary. Started at small places in the north of Argentina, and then has evolved to network around the world, and Free Software Foundation project adopted it as essential GNU project. Currently, as I said, we've been used in different places to have large implementations, like in the case of Jamaica, where you did at national level. And just came from Laos. We used at the CMR, Center of Rehabilitation. And then, as I said before, there are many places around the world where private institutions and public health systems are making use of it. So, in a nutshell, I would say that GNU Health is based on levels. The level deals with people, okay, the people, the community. We have the domiciliary units where we have families, and we deal with operational areas, sectors, institutions, and so on. Graphic set, we move on to the patient. Okay, what would be the typical legal medical record? That's where we do all the doctor-patient relationship. With this, we deal with the clinical history, with genetic load, surgeries, and so on. It's taking care of the health institution itself, so that we the health center management. That's the ERP part. Okay, that's more like deal with finances, human resources, stock management, human, and areas like hospitalization, with lab information systems, so on. What we do is making sense of all the data that we've been collecting through all these previous. Okay, I'm seeing here that you downloaded. Oh, great. So we actually have moved to this press made in Madrid. It was one of the latest ones. I'm following the same slide at this point with the one that says New Health Freedom and Equity in Healthcare. So far,
Please.
yes.
We can have our question and answer at the end of your lecture. So should we proceed with the lecture? Way to start the presentation from the very beginning.
No, thank you.
So just tell me if I have to go to the next slide. Thank you.
Oh, at the very beginning of presentation, that Selena said you one that we did in Madrid a couple of so the first one just tells you a bit of our organization about GNU Solidario. Our goal is to deliver health and education with free software. When about free software, we are talking about freedom. Our two projects are GNU Health, that's the free health and education system, and health in emerging economies. That's an annual workshop that we do different places. Lately, we are doing it in Spain, and the one that we are doing next one is going to be this September 5 and 26, and there you have the www.iweee.org. We will be in Manila, in we should be very happy to see Dr. If he's going to be around there. Next, please. Some of New Health is trying to provide people that up to this point it was more into private hands. So we believe that public is a non-negotiable human right, and that's why we have done that is free software. You know this with the concentration of autonomy resources. Next, where many, almost million people have not to eat, and 2.3, almost 3 billion people live with less than 2 hours a day. People at the same time, just has this number that we see at the end of the slide. Okay. And so one thing that we want to work on the next slide is deal social diseases. Okay. Sources are those that are coming from that form of inequity and lack of empathy, and these are easy to preventable. Uh, Now we are not only dealing with the pathology itself, but we're also dealing with the economic determinants of the. So when the system will with at the very beginning with the socioeconomic determinants of health and disease, such as family violence, prostitution, drug use, human trafficking, the war, uh, diseases, malaria, HIV, and below. Of course, in the coming slides, we'll see that this is not only a problem of developing countries. And in the slides that I'm showing now, we've seen a map of the United States, where the east part is by the other developed. Okay. What you're seeing there are the list of obesity, diabetes, and disease death rates. And if you would super the maps and you will get the same exact pattern. GNU Health is about social medicine. That's part of our logo, and it talks about freedom to adapt, to improve it, and to redistribute among community. It's partly available. Today it's being translated over 100 languages. And operating system, the development framework, and all free software. That's the best software project for social benefit that the Free Software Foundation awarded us in 2011. I come to the slide that I was talking before on 4 layers that we to cope with the system. So again, doing anything related to race, we deal with people, and we try to put as much information related to the community and to the person and to his or her family in socioeconomic conditions and lifestyles, and where they are living, where they have electricity, where they have work, and so on. Good, we have done a good job on that level, putting all that information. We can work on preventive medicine. We can work on the pillars of primary care. Deal people instead of dealing with patients. But we also deal with people does not do well, and then we get the doctor relationship and the EMR, right? So that's where we have patient encounters, evaluations, and dealing with things like the genetics, family surgeries, and so on. It would be taking care of all the network of institutions that we may have in a pro level or country level, where we not have one health, but we have many. They deal with anything that is related to the daily life on health issues. And those are providers, families, the human resources, dealing with such as hospitalizations. We have to make sense of all that data. And that's where epidemiology comes, and that's where aggregation comes. For example, in Jamaica, we have now um, an engine that sends to the Ministry of Health the information that we think that is important for them to take measures. And indicators there run from the socioeconomic conditions, as we were saying, and of family violence, different types of violence, and so on. So that is something that you will customize. So the information that you want to be aggregated will go to the Ministry of Health, and the information that is more at the level of transactional, in that it's only valid or it's only relevant for specific health center won't be synchronized. You can think about management or things like this that you might not want to synchronize or aggregate in the, but it's something that you can cast to your needs. The next slide, and you will see two side-by-side charts. Okay. So when we started working on nuclear health, we are immersed more in the system of disease, where each action is by itself. Okay, we have, as you can see, vehicles, and we are doing something reactive. We are dealing with, we deal more with patients, dealing with people. More invasive, we treat more with, it's more sophisticated, and we have also the disease as the center. My idea is moving towards the system of health, where we take care, as we said before, such as affection, community, nutrition level, physical exercise, quality of the jobs. It's more transdisciplinary than the one going on that first look that we said before, we have the next slide of the domiciliary unit. It's a concept, it's a model that deals with the physical dwelling, a physical place. The Americans are dynamic. They don't necessarily have to be a family. It's just people. And I put the eyes on the demographics of that specific person. The system immediately automatically will set up in that specific need. To the project, we actually geo-referentiate that specific dwelling, and the components and the attributes are things such as the type of construction material, the number of rooms, they have electricity or not, sanitary conditions. The good thing is that we can spot uh, any to out or hotspots if we deal with indicators of family violence or malnutrition or whatever. It's important to be able to detect easily with different indicators where prevalence of those indicators that we are actually looking for on such open. We'll show you a bit on the demographics of that person. As you can see here, we deal with things such, of course, of we are dealing with. It's a person, but also it can be a patient and it can be a health professional. Sex, occupation, educational level, mother is coming from the birth certificate, status, citizenship, types of ID, identification for things like the passport or the old clinical record they have in one of specific health institutions and so on. And look for any of those needs that this person has. You may see on the right-hand side of close to country of residence, you have domiciliary unit. So the moment that you put it there, this will show you the living coming from this demographical information. That the system allows you is to give you a card. These cards are being used in different countries today. I saw it in Argentina, and now when I went to Laos, they are also using this type of ID. A QR code where you put patient and information. And it's good to show it, or, or if you have an accident, so they can just scan it and see, for example, your blood type, or have any sort of allergies or whatever. But also, it's very useful to you to go to the institution so they don't have to actually type in your ID, but they will just scan it and will have your information ready. Definitely misses the human on typing. One of that we are interested in that conversion is we want in the next slide we are showing the new citizen and patient portal. The person is no longer a passive being, but is someone that can actually do doing anything related to the fever surveys, in terms of how the domiciliary unit on dengue fever prevention, do the survey, and that information to the Ministry of Health directly. As disease or any sort of epidemic condition that you want to be dealing on your public health program. But you will be able to deal with updating your demographics, doing appointments, any problems that you might see within your family or within your neighborhood. So that would be able to be done by this citizen portal that is going to be in the version in November. Slide deal with the medical practice and health center management, the kind of new health. So new health is a set of modules or before models and reports. So depending on the functionality of the health institution, you install one or other. Not a small private than a large general hospital. So depending on what is your functionality, you will put genetics, the laboratory, inpatient functionality, and so on. In the slide, we are showing the centralized patient information. Okay, here what we're seeing is a pretty good point of entrance when we are dealing with patients. So from main patient screen or phone, you are able to have the appointment encounters such as labs, neonatal information, vaccination status, service, and so on. Meaning medical information. So the medical information will be always visible. As a matter of fact, it has basic support system that type of critical information. So things like allergies, things like chronic conditions, and active, and they are effective. They also be in this automated list of critical information. Again, from this centralized form, you'll be able to see the status and the chronic medication list, genetic and family history, lifestyle, and so on. Way of using all information or the information about that specific person. On the we'll talk a bit about big signatures. We've incorporated digital the possibility and the ability of designing any digital documents. And again, you're in charge of saying which documents you want to be able to sign and or encrypt. The level can be done at different. You can encrypt at record level, or you can encrypt at field level. And basically, what we're seeing here is a document on a prescription. You can enable cryptography on any model that you might want. For example, you can put this today on evaluation, encounters. Here we have the prescriptions, birth certificates, death certificate, lab test, and so on. About it is not when you are signing the document, you will also have the non-repudiation. Pretty much the same as signing band and pen, that very document that you have. Allows you to, is already legislated on your country or region, to go paperless. That's one of the goals that we try to do with digital systems. We want to use as few slide, we are just showing the concept of modularity, where we have one of the modules that deals with obstetrics and pediatrics. And you will try to start from the preconception in mind prior and pensionation. And such as, again, the social condition, the nutrition level of the and the mother, the obstetrics evaluation, about pediatrics, just what is the affection level and family functionality, psychosocial risk, and information. And here you have what that is automatically that is with the weight, that weight of growth and, and the anthropometric measurements that are going to be taken on the evaluations. And the slide, you see the at the bottom of the slide, you see what would be the wristband for both the newborn and the mother. One thing that we have created in New Health is the concept of disease. This was to more than one item specific pathology or disease. Example, I'm using the tuberculosis disease. If you look at TB, we can say that it is, of course, disease, and we will put it the ICD-10 code A15, talking about respiratory tuberculosis. It is also an infectious disease. Also a notifiable disease. That means that when it comes to my office and it's an index case, I have actually notified the Ministry of Health that I have a new positive of TB. And finally, it's also a social disease. Okay, it's TB. It's usually people that is poor and have their immune system depressed. The conditions that it's living. But in these in groups, I can automatic. For example, if it's notifiable, I don't have to do an manual going and saying, okay, I have this index case, but this system automatically will trigger and notify the system, the Ministry of Health. Critical info, depending on what type of they have, whether it's an active disease or it's an active infection, automatically show it. Also for reporting. Here you're able now to say different type of disease and reporting related to their grouping. And then I'll show a bit of different screening tools that are very useful for the health clinician, social worker, see what is the level of different type of additions or, as we talked before, the functionality or psychosocial risk for them and teenagers. The screenshots here we have, for example, the case algorithm screening. It also shows you of course what the level of action that this person has to alcohol, and it will give you the trend and different and see how that person progressing with her or his disease. We incorporate recreational drugs that are recreational drugs classification and like the Schmidt-Stein family functionality test, among many others. So now I will talk about interoperability and what we've been working on in the later versions, and I would like to focus on HL7 Fire standard. The reason to incorporate HL7 Fire is because, our opinion, get the best of HL version 2 and HL7 version 3. It's well clear and well documented. You are going to be able to get the resources of specific and then this information not as from the GNU native client, but now you are going to be able to retrieve and update information in H7 Fire. So imagine different communication with existing patch servers, and we are showing the interaction with our SANC, but Icon Viewer work, and you either store the information at the GNU Health server or you can retrieve it from existing patch server that you can get institution. In the lab module, we allow you create test types. In this case, we are seeing a CBC, a clean black count test, where the analytes, where they use the thresholds on upper tips, and when value coming from the lab outside the range, you will have a call that allows you to see where we are having each of where we want to focus. If you need to make comments on those specific analytes information. Here, you are able to input data manually, and what is most reasonable and what most centers do is actually update that information from the information system. So you send your test or order to the laboratory, and then we'll send you back the results on a specific format. It can be XML, it can be web service, it can be or whatever, and just input that information automatically to the GNU Health system. The next is an easy way of export and reading the person and patient. So as we talk more on the you can have for the patient, where you have the pictures and the QR code. And you can more information in a way of encrypting it in some sort of wearable device, where, if you are type diabetes, it's always good that where you can retrieve that information on the spot. Now, in slide, we the free hardware integration. I think that this is important in the sense of having not only now software on the back end, also be able to communicate with free hardware. And we're showing the e-health sensors. We it need to put different types of connectors, such as the oximeter or the blood pressure or the EEG or whatever. Just from one single, I can plan devices that allow me to do information automatically and B, read the human error on typing. Very useful for nurses and mobile devices. And we're talking about the tools, I said at the beginning, for the health of what we are facing dealing with EMRs or health information systems are that we need a unique person code, okay? That unique person code allows to, no matter where that individual is, we need to retrieve that information, and that information should be updated on real time. I'm dealing with just one single center, that person is always going there. But reality is not like that. Today might have been seen on health institution A, tomorrow she might go to health center B, and more places around the world, you are a different person altogether in center A than in health center B. You have one clinical history in one center and one clinical history on the. And so one is creating this concept of unique ID. It's unique not only for your region or your country, but the very ID for no matter where you are in the world. It's a very unique in terms of mathematics. That number is not going to be duplicated. This is the idea that going behind the scenes in terms of synchronizing the information centers around the country. Your own social or national ID card or whatever, but that you have the UUID, as you can see at the slide, appended although as a suffix with the health institution that created that. That number is unique. And I'll aggregate the information and synchronize the information on the health centers that you have been through your life. I still dealing with reporting epidemiology and early warning systems. said, in the case of Jamaica, you have national systems. Those are the ones that run on each health center, and then you're going to have a big database, a Ministry of Health, that deal with all this information. So here, for example, we're seeing the population pyramid. So it shows you things like the new registrations, new births, new death certificates, of, in terms of diseases, you will be able to detect and prevent out early warning system based on the information that you are being from the different health institutions. And all this can be geo-referenced using street maps. The next is with the creation of the health institution and how when from that very same things such as the bed status, the buildings, the operating rooms, the units, wards, etc. And also a specialty that the institution covers, and you stay with nutrition, cardiovascular, and so on. And directors and operational areas deal with a geographic and administrative units where that specific health institution is responsible for. So, operational sectors with an area within your city or within your province that know that that health institution is responsible for the health campaigns and any sort of related to the population, the health population. The system comes from actually was therefore well on the WHO and the Jamaica Ministry of Health, and have done is to integrate it into the new health. And basically what it does is it records violent injuries, and these injuries type, and usually you record this information at the agency department, and they can go from robberies to sexual assaults to arms from car, cycle, or that happen at work, or suicide attempts, etc. They are differentiated, as you can see on the slide, the 10 encoded on that where it was how many people was involved, where perpetrator was using drugs, where guns or any sort of violent weapon, etc., etc. In that, we talk about specific health campaigns, and I'm focusing on the immunization status of the population. So, on health, you can create schedules, your own country, and in those vaccination schedules, you can also set the year of that schedule. And then, one schedule, you will set up all the vaccines with their dose and the the boosters that you will be giving. And as simple as going to to one specific child or at population level and say, okay, let's see what the immunization status of that specific child. The pediatrician or the family doctor is going to be a huge amount of time going through and seeing what the specific vaccine. That means that some has to record the nation process and also included a system. And that's the idea. Going back to that they check the immunization cards and they wait and check the cards and see what's the status of it. Now, by having the anthropometric measures shown on the growth charts, plus having the patient status it saves a lot of time to the pediatrician, and it will also reduce the error of biting one of these indicator or one of these boosters on specific vaccine. Come to the end, I would like to talk in the next slide about the vital record systems where you can actually record the certificates. And in the beginning, the demographics of that specific baby, you see that you hear the mother and the father that is coming from the birth certificate. And if we put this information, you can actually be able to begin the possibility of integrating the civil office and we will and certify one either the birth or the death. And the slide that I'm showing here on the death certificate who was person, the age, the place, it was at home, where it was at the health center, the institution, the cost, but the cost here in the immediate cause, also what are the underlying conditions and the interval that happened. So in this case, we are talking about the immediate cause of death was a rupture of the cardiac wall, but the consequence of the underlying conditions that started 7 years ago. So in this, we had a patient that suffered from atherosclerotic heart disease. That recorded was 7 years ago. 5 months pre to the death from intracardiac thrombosis, and before the rupture of the cardiac wall in acute myocardial infarction. Have document that is a medical document, but also it can use as an epidemiological tool. And today you are not just taking one single thing, but you say, we have all these conditions that result on these findings and work for medicine based on those, on the prevalence and the evidence on the information coming from the death certificate. And then administrative, well, as I said, you have to legislate and have the digital signature in place. And we've been doing and working along with WHO in the last years, and we at the ITU and WHO at Geneva on the Forum of Medical Devices and doing presentations for doing IT for women and children health. We operate of the WHO standards and the development goal 6 and 4, working with the NTDs, the neglected tropical diseases. We use the central list of medicines. We have the ICD-10 already in place. We use also standards on emission schedules and pediatric works growth charts. They are using the ICD-10 with the identification of process in medicine. But we have the ICD-10 pieces in the show just a couple of based on HIV and malaria, that's MDG6, and also in terms of neglected tropical disease, we have specific functionality on STCs and dengue, where not only we are dealing with lab tests and procedures, but also auxiliary units prevention measures, where you can do surveys on those specific domiciliary units and see what status on it. For example, in the next slide, I show an example on survey for a specific domiciliary unit for Chagas disease. So these things like, okay, what vector we are dealing with, those triatomines have been found on domiciliary or domiciliary, what are areas to improve on that domiciliary units, where is the walls, where is the roof, etc., where being backtraps in place, where has been fumigated, and so on. And again, this is something that now not only the social workers or sanitary workers can do, but also having the system integrated to the system portal and the system portal, they could report any findings on this type of information. And the slides, I'm just going to go through it quickly because I've just placed, as you can see here, a wall for the Philippines that they just have started about us from Kenya, Argentina, Dominican Republic, Jamaica, Laos, etc. And then we see the role of academia. We do the United Nations University in Kuala Lumpur, and we've been at Harvard and MIT in Boston, and University of Monterrey, Kyoto University, and so on. This is a very important part because if you, and at the end, you will have people, local people, working on those health institutions, and that is to the power and empowerment for the institution that is going to be working there are also from than the system. Next one shows you the adoption of the government of Jamaica on GNU Health and about the unique ID and aggregation. So on, they are having this on 360 health facilities nationwide. Then I think that they are on 10 already. And the, this concept is a philosophy. It's about public good and drive and drove me to start this project. And we need this public health system. We cannot have private dealing with public goods. It's an autonomy. They just don't go together. As the next slide, I'm showing the social medicine workshop congress that we are doing in Palmas next September, the 25th and 26th. And we'll be very, very happy to have you here and asking not only about the new health, but also free for in general is we want the on the 26th Richard Stallman, which is the father of the software movement, talk specifically free software in medicine. We will be doing that at the School of Medicine. I think it's a great moment to have about the current status and what are the benefits and challenges of incorporating into public health. And we last slide has to be a non-negotiable human. I finished the presentation, and I hope that I could have been able a very general idea of what is the new health project, the philosophical level, social level, and in the technical level. Thank you for your time. And now I welcome any questions that you may have.
Question, you can write it in Q&A box. Hello, everyone. Do you have any questions?
it was very clear or everybody fell asleep. I think that it was the person. Rani, could you go through the slides without a problem?
Not
Really? Hello?
Hello.
Yeah.
Thank you for your great presentation. A lot of interesting. I have one question about the PUID and the unique code in the system. It is not different. You have the PUID like, and then you have the code system different when the system generated it.
Yeah. PUID is basically something that is more a national level.
Okay.
The nomenclature normally in Jamaica, for example, they are using 3 digits, then sorry, 3 letters, 3 digits, 3 letters. So 9 alphabetic strings, very big in terms of the set, but that is national ID number. Okay, that is your first number for Jamaica, for say, but we need something that is something that you as a person is not, but something that the machine is in your code, and that is the UUID, and that huge number that you saw on the screen. That's a number that is actually going to be formation and aggregation number. That one that is actually giving you uniqueness. Well, imagine from your Ministry of Health or your civil office a couple of years from now to change the nomenclature of your ID. So that thing that we can do, so I give you a new ID. Of course, it has to be unique, and the system knows that that number or that code that you saw on the top of the slide has to be unique. But you have to have the flexibility, being able to change that nomenclature somewhere along the line. Okay? And that's why we have something that is supposed to be permanent, but at the same time allows you to change for legislation. And it's unique and it's permanent. And UUID that you saw bottom, and the number that is, or that is the code that's going to be used internally behind the scenes in uniquely identify you. And on this ID is dealing with unidentified people, MNSO or NN. Those people that come to your office with because they don't work or because they sensory loss, any means of proven that identification means. In that, the system generates an number that later on in that some office, they don't have paper, but yet I need to have that I'm going to link for this, starting with lab test or imaging test or whatever. I need to have that ID in order to do all these procedures. But then and say, hey, here is my real ID, or a family member will bring the real ID. They're able to actually put, okay, have those two. And the real number that is going to be behind the scenes, and the other is the easy identification ID that either the government or your health institution. What's the mean?
Answer. And you have a link to the White House statistic and cost update, and defined by the who will cost update, the or the registrar will register and White House record.
All depends on how your country lists. So, for example, if we're working on neonatal settings, the professional will initially put the date of birth and the place of birth and all this information, and then you have a second field that the certification entity will actually say, okay, the civil office professional will say, okay, we certify this specific or birth document or death document. But you need to have the health professional, and then you can have the worker certifying that document.
Okay.
Uh, we have one question. Is there a viable way to migrate data from an existing hospital or to GNU Health?
As a matter of fact, we have migrated different systems. Well, we did ourselves. The very same people from it all depends on is to export data from the original system. If data can be exported by means of webs or by information on a CSV format or XML format, in Kenya, for example, we entered almost 40,000 records from an existing system. It all depends on whether I can export that information. The exporting part is from the system. If done, then we can import it, both the demographics and the clinical history of the person. Okay.
All right. late in Philippines now, so I will end the sessions now. Thank you everyone for participating in session. See you the next webinar. Thank you. Thank you, Dr. Lewis.
Much for having me, and look forward to seeing you either in Manila in a couple of weeks or in Las Palmas in next. Have a
Yeah, have a great day. Thank you. Goodbye, everyone.